She is a professor of nursing at Vanderbilt. She is published on perinatal nursing, and today she's going to be speaking about birth outcomes and birth practices in the United States and comparing that to birth outcomes and practices in other countries. So please welcome Dr. Cathy Ivory.
Lovely poems, and now a professor with stats. I promise I won't be boring, I really do. So a little bit about me, because I think it helps set the stage for why I'm going to talk about what I'm going to talk about today, and why birth has kind of been my life's work. And it started when I gave birth for the first time, which I've done twice. And at the time, I don't even know, my friend Kathy Maxwell invited me today, and I don't even know she knows this, but I was happily ensconced in a career in hotel sales and catering, and then had a baby, and thought, wow, this is pretty cool, and the whole experience is great, and the people who took care of me were wonderful, and I wouldn't choose the same provider again, but you don't know that until you go through the experience and where you are and all of that. And so I decided to go to nursing school when my kids were in preschool. And with the idea that I was going to finish nursing school and go on and become a nurse midwife. And then because I was already an older student, decided I would be too old to take call and didn't want to do that. So I decided to go into health IT instead. They're the same, really, just kidding. And so anyway, I did a lot of volunteer labor support. I taught childbirth classes for several years, helped a lot of women, did their labor support as they went through the birth experience, was a labor and delivery nurse for a while, a mother-baby nurse, a lactation nurse, a high-risk pregnancy nurse. And now I talk to people about birth. And by the way, it is birth. Babies are born. Pizzas are delivered. So really, really important to me, because I think it's important that we put in context that this is woman's work. Nobody can do it but us. Not everybody gets a chance to do it. Your birth experience shapes your entire life. You remember it for the rest of your life, probably in vivid detail, maybe in more detail than you want to remember sometimes. But it's important that we all put birth in that context. So what I want to talk to you about today is the current state of birth, I'm going to start with Tennessee, I'm going to go with the United States, and then I'm going to show you some very interesting statistics that you probably may not be aware of. I promise the stats part will be short. But I want then for us to end up with some questions, because I read your philosophy of always wonder. So I'm going to leave you with some wonder, things to wonder about. Okay, so let's go. Okay, so first in Tennessee, we have about 80,000 babies in Tennessee every year. And we have a decrease in the adolescent birth rate steadily over the past few years. That's important to know, because that's something that nationally and within the state of Tennessee we've been working a great deal on. We have about 70% of women in Tennessee receive first trimester prenatal care, and that means 30% of women in Tennessee do not. The other important thing for you to know is that it's statistically, you're much more likely to receive first trimester prenatal care if you are white than if you are black. And then we have about 2% of women report receiving no prenatal care at all. But you can see how different the stat is, again, if you are white versus if you are black. We have about 3.2 deaths per 1,000 births, neonatal deaths. And again, that stat is much higher if you are a black mother than if you are a white mother. And we really don't have a good handle on maternal mortality in the United States, in Tennessee, because we have not done a good job of assessing it. So in order for us to determine maternal mortality in the state of Tennessee, we have to go back through every female death certificate and either equate that back to a corresponding birth certificate for that woman in the last year, or because there's no way to capture, we currently don't capture on our death certificates whether the woman had been pregnant in the last year, which is really how the United States captures maternal mortality. So that's important because we're going to show that stat nationwide and worldwide in just a second. So we need to get a better handle on what that's like in Tennessee. Okay, moving on. So we have about 4 million babies in the United States every year, and that's really been fairly steady, slightly declining since I've been in this business, which is really started in the late 80s. About 4 million a year, stays pretty much the same. We have about, in this country, a 32, almost a 33% cesarean birth rate. So more than 1 in 3 babies is born surgically in the United States. That rate has been steadily increasing. It went down just slightly in 2012, which is the latest statistics that I have, but that's significant, I think, when we talk about mortality and morbidity. We have about a 23%, so almost 1 in 4 women do not go into spontaneous labor in the United States, but they have labor begun for them, and which is another interesting statistic. 98, almost 99% of birth in the United States happens in hospitals. About 56,000 women a year have their babies outside of the hospital. So 56,000 out of 4 million is not a whole lot, but that number is growing. And I don't know if any of you saw, but there was I believe it was a New York Times report this week that showed that out-of-hospital unattended birth in the United States was up 79% last year. And why that might be, we'll get to in our questions in a little bit. But that's an interesting statistic also. Greater than 90% of birth in the United States is attended by a physician, and only about 8% attended by a midwife. And in the United States, in 2011, the neonatal mortality rate, and neonatal means within the first 28 days of life, so from born alive but doesn't make it past 28 days, in the United States was 3.2 per 1,000. And those are CDC stats, so they're readily available for you on the CDC site. So let's move on. So I don't want you to read those little numbers, but here's what I want you to think about. In the United States, when we spend more on health care and more on birth, we spend more per birth in the United States than many and most developed countries. Our maternal mortality rate is going up. And it's gone up pretty significantly. Now, we might think about, part of it is because I'm a data geek, and data is important to me. We have gotten, I think I suggested to you that in Tennessee we don't have a good handle on that. And we're starting to get a better handle in the United States. So part of that increase may be because we're getting better at tracking it. But whatever the reason, it's too big and too many. And women do not have outcomes in the United States that we would think, given what we perceive to be the quality of our health care in the United States. So moving on. All right, so this slide, and again, it's gotten kind of blurry for context, but Merck for Mothers. Merck, of course, a big pharmaceutical company, has taken on maternal mortality worldwide, and they've got a lot of money to do it, and so we're going to let them go with it. And I am very involved in the Association of Women's Health OB and Neonatal Nurses. We represent the 350,000 nurses who take care of women and babies every year. We have a big grant with Merck right now studying one of the biggest causes of maternal morbidity and mortality, and that's maternal hemorrhage, either during birth or right after birth. So worldwide, it's typically hemorrhage and preeclampsia or blood pressure cardiovascular related issues that lead to the deaths of mothers these days. So as Merck reports, the number of women who die in childbirth in the United States, greater than 60,000. About 2 times the number and 64th, 2 times the number in any developed nation, 64th in the world for the health of mothers. Not very good statistics. And I bet we think we do a really good job in the United States, and we really could do a lot better. So I think we're down to my wonder slide. Next. So here's what we can do. some things that we can do, and we are trying to do, and that are underway nationally and around the world. And around the world, of course, the World Health Organization sets 2020, Healthy People 2020 goals. They were Healthy People 2000, Healthy People 2010, Healthy People 2020. So every 10 years, the World Health Organization sets goals for outcomes for mothers and babies in the world. And so we look a lot to them as we determine both where we are in the United States, where we are in Tennessee, and where we are around the world. So these are worldwide strategies to try to improve the health of moms and babies. So we got to get back to the whole concept that birth is normal. And I bet if I polled you, and I used to do this when I was a childbirth educator, and then when I was working in Women's Services Administration, because nurses are also all across the spectrum on their philosophy of birth. And so if I had you all stand up and I put this side of the room that birth is a perfectly normal process and nobody needs to come near me unless I want them to, and I just need somebody to help me birth this baby, to birth is a risky procedure, and I want to have as much help, technological and otherwise, with it as I possibly can. I think you would find nurses, providers, consumers, men, women would be all across that spectrum. Many of you would be in the middle. Some of you would be way over here. Some of you would be way over here. But I think the bottom line is we need to remember that birth is really normal. Women have been having babies for thousands of years and doing it very well. And then we need to, of course, increase our access to care, and we need to increase our access to care regardless of your race and ethnicity, where you live, your socioeconomic status. And we need to do better care coordination after pregnancy. So if you do have a problem, that we're doing a good job following up with whoever's going to take care of you, your primary care provider, after this baby is born, because some of the things that happen to a woman when she's pregnant lead into a higher risk for things like cardiovascular disease and diabetes later on. So we need to have really good coordination from the time a woman is pregnant until she goes through raising these children, because we want our mothers to be around to raise their kids. Standardized approaches to emergencies, we're working a lot on that. You know, the airline industry really did this, standardized the way pilots react and checklists and all of that sort of thing, and we're really doing that more and more in hospital birth these days, where we're trying to not minimize that every birth is different, but standardize, if we can, the way that we respond to emergencies and the way we respond to care. And timely and appropriate intervention. So if you need help, we're there to give it, and we give you the right intervention depending on what it is that you need. And we don't do the wrong things that might lead to greater complications later on. We're not going to, there's some of those, and we're not going to get into them today. And no intervention unless it's timely and appropriate. So women's bodies are pretty wonderful, and they do a very, very good job. They tell us when they're ready to birth. They tell us when they're ready to start the birth process and go into labor. They tell us when that baby's ready to be born, and if we just listen to women, our outcomes might be a lot better. So, okay, now I think I'm on to questions. Yes, so questions for you to think about. So just take these with you in the next few weeks. So is birth a normal life event, or is it a risky medical procedure? You all have your own opinions about that, so be thinking about what you think about that. Who's the best birth attendant for normal, healthy women? So is that an obstetrician? Is that a midwife? Is it just a trained birth attendant? You know, in third world countries, we just want to make sure that somebody with some training is attending the woman at birth, because of the shortage of trained professional midwives. So just what training is needed? How do we make sure everybody has it? And how do we make sure that everybody is attended by the most appropriate birth provider? So we need to be thinking about that. Where's the best place to birth? You know, in the United States, more than 90% of birth happens in hospitals. Is that the best place? It's not the best. It's not the place where most women birth in many developed countries. Lots of out-of-hospital birth centers and lots of home birth. And so we did that in this country back into as late as the 1940s and 50s, and then modern obstetrics really started to advance, and birth moved from home to the hospital. And then is technology our friend? Is all the technology we use in healthcare, and we're talking about birth today and birth as an example, but is technology our friend? And when do we need to decide when to use it, and when do we need to decide not to use it, and listen to our bodies and what our bodies need us to do and when they need us to do it? And how do we assure safe access to care for all women and all newborns, regardless of where they live or what their race and ethnicity are? So happy to take any questions, but just wanted to leave you with those things to wonder about. And thanks for having me today.